everybody another minute. We'll start. All right, good morning, everyone. We're going to start in about 30 seconds. All right, here we go. Okay, good morning, everyone. Welcome to Grand Rounds. This is part of CHEO's Precision Health series and is starting at 8 o'clock this morning to help facilitate people across different departments of CHEO being able to participate. So I'm Kim Boycott. I am the chair of the Department of Genetics at CHEO, and I have the honor today of introducing Stuart. I'd like to start with the land acknowledgement. Ottawa is on the unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them and their land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors the First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. So today I'd like to introduce Dr. Stuart Turvey. He is a professor of pediatrics at the University of British Columbia, and where he holds both a Canada Research Chair in Pediatric Precision Health and the Aubrey J. Tingle Professor in Pediatric Immunology. He is a clinician scientist and pediatric immunologist based at the BC Children's Hospital in Vancouver. Dr. Turvey's research program is focused on determining early life origins of asthma and allergic disease, as well as harnessing the power of genomics to diagnose, treat, and prevent immune disorders. His ability to transition from the clinic to the lab allows Dr. Turvey to take precision health approaches that are sensitive to the developmental course of the child. His work determines and responds to the underlying cellular, molecular, and genetic anomalies responsible for disease. And I've had the great pleasure to work with him occasionally in the last few years. And so I'm looking forward to your talk, Stuart. Just want to take a moment to acknowledge that Dr. Turvey's visit, which I'll explain in one slide, and this series that we're running in Precision Health is funded by the Physician Services Incorporated Foundation from a grant from that institution, which we acknowledge and thank. And lastly, Dr. Turvey is to visit CHEO on October 27th. Book your calendars, stay tuned for more information. As you can see there are a few very interesting sessions, and there'll be some time with the trainees, etc. And so we look forward to having you when you come to visit us in person, Stuart. So with that, Stuart, I'll stop sharing and give you back the controls.
Okay. There we go. Well, good morning, and thank you so much for this kind invitation. I'm delighted to be able to speak to you this morning, and really looking forward to coming for an in-person visit later in October. And I'd be happy to meet with people and talk about precision health. Again, similarly, before I start, I'd also like to make a land acknowledgement. So I'm joining you from Vancouver, which is the traditional unceded territories of the Musqueam, Tsleil-Waututh, and Squamish First Nations people. And today I want to share something that I'm very excited about, and that's something that I've worked to establish together with Dr. Anna Lehman, and we call it the Rare Disease Discovery Hub. And we're really excited about this paradigm that's focused on supporting clinicians in patient-specific rare disease research. And so I'm going to talk to you a little bit about the nuts and bolts of this program, but really use some stories, patient-focused stories to highlight, I think, the power of this approach that complements many other approaches for rare diseases nationally and internationally. So this is me. I'm a pediatrician, pediatric immunologist. So I see patients in the hospital. My research is really directed at improving outcomes for patients, and I really live and breathe in the children's hospital. And like all of us who work in a children's hospital, we appreciate the importance of rare diseases in this population. And Dr. Boycott, who kindly introduced me, is a global leader in this. So I'll be very brief in sort of introducing rare diseases. Suffice to say that they are in aggregate relatively common. Many children who are admitted to our pediatric hospitals have a rare disease. Many we still don't know the causes and working hard on that. I think tragically is this concept of the diagnostic odyssey, where children and families affected by rare disease have a frustrating, time-consuming and painful journey in search of a diagnosis, which thankfully now we often do get a diagnosis, but certainly in the past, these diseases didn't have names, their underpinnings weren't known. And so this odyssey really never ended. And then within the theme of this workshop series, I think understanding the genetic cause of a child's rare disease really opens the vista for precision medicine, where we can precisely understand the molecular cause of their disease. We can understand and predict potential adverse outcomes and look to avoid them. And we may even be able to use therapies that direct their specific genetic change. And so rare diseases really are something that matters very much in the pediatric health setting. And when we think about genetic discovery for rare diseases, for Mendelian or single gene diseases, I think we appreciate that the landscape has changed, and that change has been driven by technology. So from about 2010 onwards, we were able to apply next generation sequencing techniques, initially whole exome sequencing, which would sequence the protein encoding regions of the genome, and then more recently whole genome sequencing, which has greatly accelerated our rate of discovery of genes responsible for these diseases. And for me as a clinical immunologist, it's really exciting times, and we see this rapid rate of acceleration. So I started my faculty position in 2004 here in Vancouver, and so to pass the exams at that time, I needed to know about 100 conditions. I probably did know the 100 at the time. Now we're close to 500 in the field, and I would be honest to tell you that I do not know every single monogenic immune defect. But we're able to leverage this knowledge and really diagnose so many more of our patients. And so when I'm in the clinic, or when we're in the clinic and we're thinking about a genetic workup for a patient, it goes something like this. We we obtain approval for the genetic test, or we work with our colleagues, perhaps in medical genetics, who will do that test. Blood's drawn, goes to a lab where magic happens, and I'm not going to get into the details of the sequencing. And then a report's returned to us that identifies genetic changes in the patient, and we call them variants. And then those variants are classified traditionally with 5 potential classifiers as to their likely meaning. In green, we see variants classified as benign or likely benign. That's helpful and makes it unlikely that those are the cause of the patient's phenotype. Variants might also be classified as red, as likely pathogenic or pathogenic. And so those variants, if that gene matches the patient phenotype, that may start to give us an answer for what's going on. But the difficult reality with the genetic testing and the status of our knowledge of human genetic variation is that we often get a variant back that's called a variant of uncertain significance, a VUS. And that happens because there's insufficient evidence from the variant, from population knowledge, to refine that classification any further. And so we're left with a VUS, which is really clinically unactionable, and I think is very frustrating for everyone potentially. And I think it's important to appreciate that the VUS really shouldn't be acted on clinically. It should be it needs to be understood better. And so, what are some of the options we have potentially to reclassify a VUS, to understand if it may be more likely to be benign or maybe more likely to be pathogenic? And there's a variety of approaches, and here's 3 things that I do, or I might do. So the first and perhaps most obvious would be to segregate that variant within the family. If there's other healthy family members, and we start finding that variant in multiple healthy family members, that really suggests that variant's unlikely to be causing the disease. So that can very much help us. Another option is really to be patient and wait as the field evolves and as our global knowledge base evolves, and we start to accumulate evidence from other cases and other populations about this VUS and the phenotype. And that is really important over time, that VUSs can be reclassified based on expanding global knowledge base. And some of the sequencing companies will reassess the variants over time and help reclassify them. And a third powerful option is to involve the research lab and to perform experiments that might mimic this variant and observe how that changes the phenotype. And this is really where we tried to step in. It was in this lab component, and we really wanted to see if we could support clinicians and in their patient-focused efforts to use a research lab to help resolve these unresolved genetic changes. And so I want to strongly acknowledge my partner in this initiative, Dr. Anna Lehman. So Dr. Lehman is a medical geneticist and expert in biochemical diseases at UBC and at BC Children's Hospital. And together we've led the establishment of the Rare Disease Discovery Hub. And this work would not have been possible without Dr. Lehman, who was remarkable at this work. And together we've come together, and we're hugely fortunate to be able to be supported by our BC Children's Hospital Foundation to establish this initiative. And what was our motivation? It was pretty simple. It was really about wanting to help patients and their families who had needs beyond current clinical care These patients and their families had got to the edge of what our current clinical capacity provided. They and their treating clinicians were stuck, and we felt that with the research lab, we could advance their care. That was really what it was about. We're also excited that the research enterprise could be really enriched by active engagement of academic clinicians, that the research institute didn't need to just be supporting clinician scientists who had their own labs and their own lab capacity. We could leverage the expertise and passion of the broader clinical community. And for that, we wanted to reduce the barriers for a clinician, a busy clinician, to really start to do these types of research. The hurdles were essentially insurmountable, and I think we recognize that. So that we thought the hub could take responsibility for the ethics, the contract, the people who do the work, the research space, the equipment, and some of the funding to push this together. And then finally, this, beyond our clear focus on the patients, we recognize that this had ripple effects and would benefit our institution at a larger level. Some simple pragmatic things. If the hub held the ethics, there would be fewer ethics applications driven forward by clinicians for individual patients. We'd be able to support the clinicians and provide that experienced oversight for things that they have no reason to need to get involved with. A lab biosafety certificate, the IT infrastructure for analyzing these works, simple examples. One thing that this has turned out to be has been a remarkable opportunity for trainees, both trainees on the clinical side who come to the lab with the patient they know and start to understand what happens on the lab side, or for basic science trainees who get to see and be engaged in real translational research. And then finally, I think we've proved that by establishing understanding patient stories, we've empowered more successful applications for external funding. And so our aims in this were really to improve the understanding of the mechanisms underlying some rare diseases affecting our patients at BC Children's Hospital, to identify potential treatment strategies that we may be able to apply precision health approaches. I think we've really succeeded in uniting at some level our patients, the families, clinicians, and basic science researchers, and we've created and continue to create a nice network linking these. About 2 more slides and kind of the nuts and bolts of this, and then we'll get into some of the I think maybe more interesting patient stories. So the way we set this up was really 2 phases. One was simply offering a service to reanalyze whole exome sequencing data. So clinicians may have had whole exome sequencing done by a company perhaps, or through other mechanisms. And we essentially had low barrier process where we would enroll their family, get the consent, access those data, and reanalyze the genetic data to see if there were things that may be candidates there. So low barrier access to that. The phase 2 work was really about doing functional studies in the lab. And so for this, we were looking to partner with the clinicians. So the referring physician would present to an advisory committee we'd set up. This advisory committee included medical genetics experts, lab medicine experts, genetic counselors, and it was really a sort of fantastic engaged group. And the committee would collaborate with that referring physician to understand what's this genetic change they feel is responsible for the patients, and did we feel that evidence was strong, and then work together to identify what experiments could be done to advance the patient case to a diagnosis, and identify potential collaborators, whether the work would be done locally within in the hub, or whether we partner with the best people wherever they might be. And I think central to the success of this has been positioning the physician at the center of it, positioning them as the champion of these cases, so that they speak with the family, they share this information with the family, are really involved in every step of the process. And so what do we do with the Rare Disease Discovery Hub? So if a patient, if a physician comes to us, they present their case, and it's accepted through the advisory committee, we really provide full support. So we provide an REB approved research protocol. We give them this peer expert advice. We provide the genomic reanalysis. When the patients are accepted, we then consent the participants. We arrange the sample collection. We, for example, prepare cell lines and others and ship them to the collaborators after handling the appropriate material transfer agreements. We work hard to ensure that everything is done perfectly in terms of patient privacy. And then we do work either in the local hub lab or engaging the collaborators. And we essentially pay for all of that work to be done. So with that kind of nuts and bolts background, I just wanted to tell you some stories, and really it'll be two stories. One I think relatively simple story, and then a larger story. So the first example of a success story from the hub was this story of a family with a question of whether they may have Peutz-Jeghers syndrome. So Peutz-Jeghers syndrome, we may remember, is a rare autosomal dominant condition where the affected individuals are noted to have melanotic macules, maybe most obviously in the lips, as we see here in the boy in this family, but can be elsewhere. And they can have polyps through the gastrointestinal tract, which are predisposed to a high risk of malignancy. And so in this patient story, one of the physicians from medical genetics, Dr. Neil Burkall, had been following a father and his son who had features of Peutz-Jeghers syndrome. Not all the features, but some features. And this was important to resolve, because people with confirmed condition, due to the risk of malignancy, will be entered into a very high intensity cancer screening program. But where Dr. Burkall was with this was that the family weren't eligible for enrollment in the program, and they were stuck. Because what he'd done exome sequencing in this family, and had found a genetic change in a gene called STK11. And STK11 is the most commonly involved gene in Peutz-Jeghers syndrome. And they'd found a genetic change in the intron of this gene that was classified as a variant of uncertain significance and was not actionable. And so everyone was stuck. And I'll explain a little bit about where this variant was. And so Dr. Burkall came to the hub with this story. And as the advisory committee looked at it, we saw that, maybe I should back up and just remind us about splicing. So I think we may remember about splicing that as we move from genomic DNA through to mRNA, the introns are spliced out, leaving the exon. So here in this example, we have exon 1 in blue, exon 2 in this orangey pink color, and then the intronic region here. And so as this is processed, that intron spliced out by accessing the splice acceptor site here. And this genetic change affected, caused an A to G change, 6 base pairs into the intron, and created a new AG acceptor splice site that may lead to, that we thought could potentially lead to the addition of 5 base pairs in that mRNA. And what that would do would actually change the genetic code and encode for a premature stop codon. And so this could be a potential explanation for the patient's disease. So in the hub, we did quite simple experiments, to be honest, just looking at the structure of that mRNA. And what we're able to see here in the Sanger sequencing of the boy here called the proband and the father who was also affected was that the sequencing becomes really disrupted at this point. And through other techniques, we're able to establish that in fact this 5 base pair, there was this 5 base pair addition into the mRNA. So essentially, we established that this genetic change was disrupting the mRNA in the patient and in the father and the son, and hence explaining the patient's disease. So here's Dr. Burkall. Dr. Burkall returned this information to the family, who were extremely grateful. He, as the medical geneticist, was able to reclassify this VUS as likely disease causing, and enter the patients within the appropriate cancer screening. And from an academic perspective, this story was then published actually just last week in the American Journal of Medical Genetics, describing the value of this approach. So I think a nice example here of the fact that through the Rare Disease Discovery Hub, we were able to do what were really very simple experiments from a wet lab perspective, but have huge impact in the ability of Dr. Burkall to appropriately manage this patient. So we were pleased with that. We thought that was really a nice example of a win for the Rare Disease Discovery Hub. And for those who are sort of expert in this field, these splicing questions have been perhaps the most popular cases to come to the hub, because these are ones where there tends to be no, at least in British Columbia, no approved approved testing or clinically approved testing that allows the patients to move forward. And so just from a nuts and bolts perspective, here are some of the numbers. Somewhat surprisingly to me, the phase 1, this exome reanalysis, which I thought would be hugely popular, has been moderately popular, and not that many people have come to us, but we've been able to complete cases and actually find a couple of strong candidates that hadn't been seen through the original analysis. But what's proved to be extremely popular has been the phase 2, really the wet lab work supported by the advisory committee. And so the hub has been up and running now for about 2.5 years. We've had about 80 projects proposed, 60 have been presented, and most of those have been approved here, 54. We've completed 8, meaning we had an answer, and have a good number still ongoing. And one thing I'm proud of actually is this, that we've had really quite good enrollment or engagement from physicians across our campus. It's not surprising, and it's appropriate that medical genetics physicians have referred half our cases. And again, not surprising, I think that biochemical disease physicians have provided the next largest chunk to get together with neurology. But we have included a good number of other specialties. And I would also point out that some of these patients, particularly who have come from medical genetics, have multi-system disorder, and so we've been able to actually involve surgeons, orthopedic surgeons, oncologists, and others in these cases. And Again, we don't do it all in-house. I gave you an example of in-house work, but we really just want to leverage what's best in terms of global expertise. And so we've sent, here's an example of places we've partnered with and arranged material transfer agreements and sent samples to a variety of other labs. Okay. So so I've given you a bit of background about the Rare Disease Discovery Hub. I've shared my passion for how the wet lab research can really transform a patient journey and the ability of physicians to manage patients. And I've given you one example of a relatively simple story. The next story I'd like to tell you is a bit more complicated, and emphasizes the fact that at all our hospitals, all our tertiary children's hospitals, there are patients with previously unrecognized and undescribed human diseases. They'll be walking in the door of our hospital today. And I think it's very exciting when we can start to make those diagnoses. And so I want to tell you a story about a patient and their family for whom we were able to make a diagnosis and identify really the first case in the world. So this is I think a remarkable story that was brought to us by a group of 3 physicians: Dr. Milan Patel, who's a medical genetics expert, Dr. Tony Cooper, who's a pediatric orthopedic surgeon, and Dr. Sylvia Chung, who's a pediatric oncologist. And they came to us as a trio of caring physicians to tell us the story about this young man. And so this story is a story about a young man who's the oldest living member of his family. So he had arrived as a refugee in Canada about 2 years before we saw him. He was 16 when he arrived in Canada. His parents were consanguineous. His parents were third cousins, and they had 4 living children. They had a number of children die as well. And his story was that he was born, and he was a normal, healthy young child until around the age of 2. So he developed normally. He walked at 1. He was developing appropriately, and then from the age of 2, he started to develop progressive difficulty with ambulation. That was noted initially, but then really developed progressive non-inflammatory joint contractures that essentially affected all his joints. So he ended up with fixed flexion contractures in his knees, his hips, and so he had huge difficulty with ambulation and movement. Really all his joints were affected. And interestingly, he was also noted to have multiple osteochondromas in multiple places. So down here, I'm showing his chest X-rays, his knee X-rays, and this lateral view. I'm really showing you that to show you the extent to which he could extend his knee. So really profound fixed flexion contracture. Relative normal structure of these joints, but some abnormalities due to issues with the way weight's transferred. And here's an example of one of these osteochondromas, but there were multiple of those. So he had difficulty walking, but was otherwise well. And then at the age of 18, he developed he was diagnosed with lymphoma, and the pathologists classified it as what they called an unclassified B-cell lymphoma. So it had features that were intermediate between diffuse large B-cell lymphoma and classic Hodgkin lymphoma. So it was somewhat unusual to be unclassifiable. He was treated appropriately, went into remission, and was well for 3 years. And then at the age of 21, he returned with lymphadenopathy and B symptoms of fever and weight loss. And then subsequently was diagnosed with classic Burkitt lymphoma, including the classic translocation. So when the doctors came to see us, they said, this was a remarkable story of unusual features. This joint and bone disease, recurrent B-cell lymphoma, and they had done genetic testing and had found that this patient was homozygous for a complex genetic change that was predicted to cause a premature stop codon in the protein NFAT1, which is encoded by the gene NFAT-C2. And I'll explain that in a moment. And so here we looked at the segregation through the family, and the patient is homozygous, so carries 2 copies of this variant. And then all his living family members were heterozygous for this, but none, and all were healthy. None had any of these features, although we'll point out that this sister had achondroplasia and was thought to have sort of classic achondroplasia. So what are these NFATs? So NFATs stands for nuclear factor of activated T cells. So this is a family of transcription factors. They're best understood in T cells, and hence their name, but they're known to be important in other cells, including and relevant for this story, B cells and chondrocytes. The nomenclature here is terrible, I would say, because the gene names and protein names don't line up. So NFAT-C2 is the name of the gene that encodes a protein called NFAT1. And that's the one we'll be talking about today. And there's 5 members of the family. The first 4 are activated by changes in intracellular calcium, and NFAT5 is regulated by osmotic stress. And so we won't be touching on that. So yeah, this is terrible nomenclature, I think, and makes this really quite confusing. So when this came to us, we did what everyone would do, which was type NFAT-C2 into Google and joints, and what comes up was a remarkable paper published now over 20 years ago by Laurie Glimcher, where they had made NFAT-C2 knockout mice. And this is the quote from the paper. After 6 months of age, the animals developed progressive difficulty in ambulation, accompanied by fixed contractures and significantly decreased range of motion. That's exactly what this young man had starting around 1 year of age. So that was really compelling. And then digging into this transcription factor more, there was a good number of papers talking about the importance of this in B cells, controlling cell fate progression, and being relevant to tumors. And so this seemed to us like an amazingly strong candidate. And we were excited. It seemed that this patient's phenotype may well be explained by this genetic change affecting the protein NFAT1. But we had to go on a journey to prove that, and that's what the hub embarked upon. And ultimately, what we were able to show was that this patient has complete deficiency of the NFAT1 protein. And so let me take you through this a little bit. So NFAT1 is a transcription factor that is maintained in the nucleus, and in the inactive state, it's heavily phosphorylated, and it sits there heavily phosphorylated. And then when activated, it's dephosphorylated and then moves to the nucleus, where it's able to drive the expression of important genes. And this dephosphorylation event happens when there's increased intracellular calcium, and we recognize that is a classic signaling secondary is a classic intracellular signaling change that happens, for example, when the immune system's turned on. Intracellular calcium goes up. That activates the calmodulin calcineurin system, and then that is what dephosphorylates the NFAT1. And we also know that calcineurin inhibitors, such as tacrolimus or FK506, or are classic immune modulators because they block this, and we use these in transplant rejection, preventing transplant rejection, for example. And so with knowledge of that pathway, we wanted to look at the patient. And so here down the right-hand corner, we have a Western blot or immunoblot looking at expression of NFAT1 protein. We also look at beta-actin as a housekeeping or loading control, and we see that there was good expression of beta-actin, equal expression across all these samples. When we look at the healthy control here, designated HC, we can see that in the resting state, there's a clear NFAT1 band. After stimulation with inomycin, that raises the intracellular calcium, we can detect that dephosphorylation event because the protein becomes lower molecular weight and migrates further on that band. And then in the presence of FK506, we can see that dephosphorylation is blocked. So that's what it should do. That was perfect. Here's a heterozygous family member. Protein levels of the NFAT1 are lower, but the performance of the protein is intact. And then here's the patient, absolutely no detectable protein. We then wanted to do some experiments to understand what was going on here. And we were fortunate to be able to actually, with the patient's permission, we're able to actually grow patient chondrocytes. He'd gone to surgery with Dr. Cooper, looking to reconstruct some of the joints to improve his range of motion. And when Dr. Cooper was performing the surgery, he removed some of those osteochondromas because they're known premalignant potential. And again, with the patient's consent, we were able to grow out those patient chondrocytes. And then we used a sort of classic molecular biology trick, which was to take the patient chondrocytes and then transduce them so they would express the wild type version of the NFAT2 gene. And so then we had a nice matched pair, and we can see that over here. We had the patient chondrocytes that had no NFAT1 protein at all. They were just transduced with a control empty vector. And then we had been able to rescue and normalize the patient's cells by expressing this NFAT1 protein. And then we were able to compare these two that were matched for all the other genes except for the presence or absence of the NFAT2. And we're able to do a number of techniques here. I'm showing you RNA-seq, which looks at the gene expression. And the details are not too important, but what we're able to see was that in the patient cells, there was upregulation of signals related to survival and signals related to inflammation. And so it was important for us to prove that experimentally. And so here we looked at cell survival, or here we looked at cell death. And we can see that in the patient, in the patient cells, the cells died at a lower rate here in red, the patient cells, compared to the normal wild type cells, which died at a higher rate. And we thought that showed some sort of proliferative advantage of those chondrocytes and might help understand the joint disease. And we also saw an exaggerated inflammatory response in the patient cells here in unstimulated, the red being higher than the blue, secreting IL-6, and here after stimulation. So we started to understand what was going on with the patient. In the next few slides, I'm an immunologist, so I can't resist showing you some immunology. So we wanted to look at some of the patient's immune system cells. We were worried that this was going to be a bit more complicated because what was known is that that family of NFATs seemed to cooperate to control the immune response. And so the immune system changes were really obvious in mice who were lacking, say, 2 of the transcription factors, the NFAT transcription factors, but were much more subtle in patients with 1. So there was clearly a lot of cooperation and even redundancy, it seems, between the NFAT1 proteins. But when we looked at the patient cells and looked at the patient's immune system, we really saw some important signals. So one was this we saw accumulation of naive B cells. And so here is flow cytometry. Here's a healthy control. So normally we start, this is an age-matched healthy control. Normally we start out with naive cells, and then as we experience antigens and have infections and are vaccinated, those B cells mature. And so we end up with cells in different quadrants here, moving down here to the mature cells. In contrast, the patient, essentially all the cells were stuck up in here in this naive compartment, and we didn't have any maturation. That was interesting because from a clinical immunology perspective, this patient didn't have an immune deficiency. He had normal serum immunoglobulins. He made good titers against antibody titers against vaccines and past infections, and he really didn't have too many infections. But he did seem to have this interesting developmental arrest. And we were able to quantify that in various ways. And when we looked at these B cells using a technique called single cell RNA sequencing, what we were able to see was that there were really a lot of these naive B cells. And again, I don't want to get into the details of this, but this population are the naive B cells. This population is the mature B cells. Patient really has no mature B cells compared to the controls. But when we looked at the expression pattern of these naive B cells and compared them to the controls, we again saw this concerning signal that could help us understand maybe the malignant potential. So it's increased abundance of pro-survival, proliferation, and anti-apoptotic genes. So the patients seem to be set up to be more oncogenic in those naive B cells. And then the final little bit of immunology I wanted to show you was the fact that the T cells that he had really seemed to not function appropriately. And what I'm showing you here is that we're able to stimulate those T cells and then measure some of the classic cytokines they secrete. And what we see is that in the healthy control, most of the cells end up in this quadrant, meaning that those cells are expressing the classic inflammatory cytokine TNF alpha, and also expressing the cytokine interferon gamma. And so that's what most cells will do. That's what's normal. But again, this patient failed to make that population, and so had some problems in his ability to make cytokines. And so this was all nice. We were able to show you, associations, one rare patient with changes in his B cells and T cells compared to a pool of healthy controls. But as we're also able to do a genetic proof experiment where we can add back the gene to the patient's own T cells and see if that rescues the phenotype. And this is a really powerful strategy to show that these associations are really mechanistic. And so again, similar to what I showed you before, the normal healthy control has most of the cells up in this corner making the cytokines. The patient has none of those. And then with the rescue, we start to rescue that production. So end that longer story by just saying that really through the partnership with these remarkable clinicians who recognize this patient and the fact that we had the Rare Disease Discovery Hub, we were able to make a diagnosis for this young man, and then advance, I think, our understanding of human biology by describing the first human with complete NFAT1 deficiency. And yeah, this paper was just published very recently. So I end my last slide by just saying that through this work, we described human complete NFAT1 deficiency, which we think is a new inborn error of immunity. And in our patient, the triad was really about the joint contractures, osteochondromas, and B-cell malignancy. But clearly, this is one patient, and more patients will be needed to define that phenotype. I think this human discovery validates decades of predictions made from the mouse knockout studies. And what we're seeing here really is multifactorial mechanisms of disease. So quite a complex mechanism of disease, and we haven't defined all of that mechanism. So I'll end by saying thank you for having me. I hope I've convinced you that the Rare Disease Discovery Hub and having a mechanism to advance patients to the research lab has been transformative for our patients, and Dr. Lehman and I are passionate about doing more of this and sharing this experience. So thank you for having me.
Thank you very much, Stuart. That was fantastic, and of course, you know, my interest in rare disease means I love it even more. Just a quick question, if you can share with us. So I think you mentioned that the Rare Disease Discovery Hub was supported by your foundation.
Yeah. Yes.
What type of funding is required for this sort of infrastructure, since you're managing like 100 projects have come through in some form, right?
Yeah. So we're pretty. I tell you, we're quite lean. We need to grow, but basically, we have what do we have? We have 3 full-time employees right now. Four full-time employees. We have 2 people working in the lab pushing projects forward, full-time lab technicians, and then we have a fantastic coordinator who manages the ethics, the patient consent, the material transfer first. So that's what we started with in terms of people, and then we basically just the people work essentially in my lab space where we have equipment, so we haven't had to buy equipment for this. If you look carefully at our little flowchart I showed you, is that we're sort of getting a bit of a backup in terms of projects that are not completed. So we do need some to increase our throughput, but we started out, you know, modestly, and have made some big difference with those 3 people essentially. So that's the scope of it right now. So it's not huge, to be honest.
No, but it really is just bridging that little gap, especially for things like the first example you showed with Peutz-Jeghers syndrome, where RNA-seq or RT-PCR will finish that for that family. It's pretty small, but we can't get it clinically.
Yeah. So that was what made me crazy, that, you know, a grad student can do that experiment in, you know, a day or 2, to be honest, for, I don't know, like a small amount of money. And these patients were stuck, and that's made me crazy.
Yeah, well, we really need to move that sort of stuff into clinical care. Okay, Mark, I see you have a question. Please go ahead, Mark.
I do. Thank you, Kim. Stuart, that was, as interesting goes, that I found that profoundly fascinating on lots of different levels. It brought me back to my undergraduate degree. So thank you for that. I work primarily clinically in mental health, and I noticed on one of your slides that where you were outlining kind of who was sending your referrals, that you had a handful of referrals from mental health. But I'm curious, you know, so we've started pharmacogenetic testing more frequently in a lot of the patients that we see with eating disorders, and I'm not sure if it's chance or if it's, you know, related to our sample, but certainly a lot of the patients that we see, that we get these reports on, they're less than straightforward, I would say. Not what we would expect as it relates to at least what the evidence would suggest we should be doing in regards to pharmacotherapy and their gene and allele activity, which of course makes me wonder to what extent, you know, the chicken and the egg as it relates to just their genetic makeup. And I'm really curious as to, you know, if you can, I don't know if you have any of that feedback, but we see a lot of patients that have a constellation of symptoms that sometimes fit neatly, but lots of times don't fit neatly into, what I'll say is a disease or a diagnosis. And you've used medical examples in some ways to highlight kind of these different constellations, but I'm really curious as to know as to whether, what's been going on in mental health.
Yeah, so thanks for that question. I think, the hub is sort of focused in where we tackle patients. We're about the clinicians coming to us sort of with a genetic variant in hand, and then we assess the evidence for that and move it forward. And yeah, I too was delighted when the psychiatrists came to us with I think compelling single gene defects for patients in their practice. And I got to stay in my lane. I'm a pediatric immunologist, so it gets risky when I start talking about sequencing. But I think what's become clear is that it's important for us to have an open mind, and at least in my clinical immunology practice, the patients who have single gene defects that explain the diseases are the ones where experienced clinicians recognize that this is outside the spectrum of what they normally see for their disease. So it's earlier onset, more severe, more. So I'm getting out of my lane in terms of being an immunologist, but I think my passion is that we take this sort of genetic technology across the spectrum of disciplines and start to realize that, and we do realize, but that single gene defects will be in all patients with that will be in all our practices, and spreading that. Medical genetics has done a great job of that, but I would say, the average pediatrician or subspecialist pediatrician in other disciplines, my allergy colleagues, for example, don't often think about that. Mark, I'm not sure I answered your question at all. I'm sorry.
It just highlights the work that we need to do in mental health, but thank you.
Yeah.
Still fascinating, all fascinating.
Okay.
Great, thanks, Mark. Last question, Anne.
Hi, Stuart. Thank you so much for your talk. It's always a pleasure and so inspiring to hear you. So I agree. Clinical immunology is essentially a specialty of rare diseases. So I think the first message that hopefully you've sold to the group is to recognize and to kind of think about these patients that are on these diagnostic odyssey, that there's something that could be done. My question is, obviously these rare diseases, you need a lot of collaboration, and I just wanted to better understand the landscape in Canada, how it intersects with Care for Rare, the Silent Genome Project, and other of these kind of initiatives, but from a clinical perspective, not necessarily a research base.
That's a better question for Dr. Boycott, who's really been the national driver of these. But I think, I think it's, for me, what it, so Care for Rare as an example is as something that is very prominent in our organization. Dr. Lehman, I spoke to, is the pushing forward on Care for Rare. We worked hard to for the hub to complement what was there in terms of Care for Rare. I also think it's important to be able to sort of have these stories, the patient stories, that help us drive forward things in our local jurisdiction. So, healthcare in Canada is provincially distributed, and so we have to fight the good fight, I think, in our local environment to have access to next generation sequencing, for example, to move the splicing forward. And so I think that the simplest answer is, is to reach out to people who are involved in these networks locally who can help. You guys are so fortunate to have Dr. Boycott. And we're not looking to replicate anything. We're really about, I think, filling this niche for the patients right now.
Mm-hmm. Almost locally, right, Stuart? Yeah. So, I think, Anne, Care4Air offers many of the things that are similar to what Stuart's Discovery Hub is offering. But again, when you move those particular projects into the wet lab, it tends to be much easier if the patients are local because of the sample type collection and the follow-up and all those sorts of things. But all of the things we've talked about, including Care4Air and Silent Genomes, they're all research, right? And so they operate in that space, not in the clinical space at this present time. Thanks. Good. Okay. Well, with that, we're just a little over, so we better wrap up. But Stuart, very much appreciated you joining us this very early morning. And we look forward to having you come to see us in a few weeks and show you around in person.
Thank you.
Okay. Thanks very much, Stuart.
Okay.
Bye.